Welcome to today's lecture in which I will introduce the abdomen. My name is Carlos Andres Suarez-Quian and I am the creator and narrator of this lecture. The objectives of this lecture are written here. At the completion of this lecture, you should clearly be able to define the abdomen, be able to describe its relative location with respect to other body cavities, be able to relate cartilaginous and bony elements relevant to the abdomen. These are structures we mention often in clinical medicine. Describe the divisions of the abdominal wall, vis-a the content of the abdomen. And finally, recognize that surface projections of the abdominal content form part of the physical exam. Let's start. Let's mention at the start that the abdomen is the largest space, cavity, of the body, and yes, if left unchecked, it will continue to grow. The abdominal cavity lies between the thorax and the pelvis, and the abdominal cavity holds many of the organs responsible for digestion and metabolism, and also houses organs of the urinary, endocrine, exocrine, circulatory, and reproductive tract. Learning about the abdominal cavity is just the beginning step in how to appreciate the abdominal physiology and how important a role it plays in normal homeostasis. Consider this just the beginning of a very long journey. I mentioned in the previous slide the relative position of the abdominal cavity, that it lies below the thoracic cavity and above the pelvic cavity. Here we see a partial skeleton and we can easily identify the thoracic cavity above the abdominal cavity, the latter which is superior to the pelvic cavity. Note that there are no bones per se in the abdomen, although we will need to learn bones that are of clinical relevance to the abdomen. Given that we have no bones providing protection to the abdomen, what do we rely on for protection of the vital organs found in the abdomen? The answer is skin, fascia, and muscles of the abdomen. Indeed, the muscles and tissues found in the interior abdominal wall are of significant clinical relevance, and we will discuss them in detail in a later lecture. We now see a lateral view of the bony skeleton and again point to the thoracic cavity, the abdominal cavity, and the pelvic cavity. The last is masked by the lateral wall of the pelvis. And what can we see is that the diaphragm separated the thorax cavity from the abdominal cavity, albeit there are connections which we will discuss later. Structures do traverse the diaphragm and are found in both cavities. In contrast, the abdominal cavity is contiguous with the pelvic cavity. And think for a moment, what are the implications of this simple fact? Anything found in one compartment can flow freely to the other. And here I want you to think about infections. Yes, abdominal infection can lead to massive peritonitis that involves the pelvic organs, and in turn, a pelvic infection, think of a ruptured fallopian tube, can lead to abdominal peritonitis with fatal outcomes. Indeed, just by describing the cavities of the body, you begin to gain significant clinical understanding of how disease afflict our bodies. Having mentioned that there are no bones per se within the abdomen, nevertheless, certain bones are important to know and form attachment points for abdominal structures. We start with the lumbar vertebrae and the last thoracic vertebrae. They help form the posterior bony wall of the abdomen. We then identify the cartilaginous costal margin. This margin is formed by ribs 8 to 10 attaching to the cartilage of the rib above instead of directly to the sternum. you can palpate the costal margin on yourself. The xiphoid can often be palpated and represents the inferiormost part of the sternum. Moving to the hip bone, we note the crest and the tubercle, all important for muscle attachments. The anterior superior iliac spine, ACEs for short, and the pubic tubercle are important attachment points for the inguinal ligament. We will discuss formation of this ligament in detail in a later lecture. Finally, where the right and left pubis meet, the location is known as a pubic symphysis. Clinicians commonly subdivide the abdomen into quadrants, and the reason for this will become apparent shortly. The abdominal wall can be divided into quadrants or regions by means of a horizontal plane passing through the umbilicus and a vertical line in the median plane extending from the xiphoid to the pubic symphysis. This renders 4 quadrants that are given the following names: right upper, left upper, right lower, and left lower. It is also possible to subdivide the anterior abdominal wall using an imaginary plane at the subcostal plane, the transtubercular plane, and 2 midclavicular lines. These additional planes now render the anterior abdominal wall into 9 regions: the right hypochondriac, epigastric, left hypochondriac, right lumbar, umbilical, left lumbar, right inguinal region, hypogastric, and left inguinal region. Each region is logically named. For example, right hypochondriac refers to the region below the cartilages of the right thoracic ribs. Hypo refers to inferior, and chondriac is another name for cartilage. Umbilical, as you can surmise, infers the region of the belly button. Epigastric means above the stomach. Gaster is another name for stomach, and so on. I should mention, however, that these subdivisions into regions are really done for academic reasons, and you do not need to memorize them for any exam. Nevertheless, why go to this length to describe these additional regions if they're not used clinically? The answer is here. We have now added the abdominal viscera to the previous image and included the planes of division. Let's describe how the viscera projects on the surface of the planes we just named and the clinical implications of knowing this information. The liver lies under the ribs, extending to the right hypochondriac and epigastric regions, and for the most part cannot be palpated, except in kids. What does it mean then if you can palpate the liver outside these regions? Most likely, the patient is suffering a diseased liver. The liver is enlarged and is manifesting some pathology. It is not a good sign to palpate something hard below the costal margin. The gallbladder lies opposite the tip of the 9th costal cartilage. Constant pain that does not dissipate in this region, needs to raise awareness that the patient may be suffering gallbladder disease. That is, a stone is blocking the bile exit and requires surgery, called a cholecystectomy or removal of the gallbladder. Look where the stomach is located, in the epigastric region. Think of when you have complained of a stomach ache and grab your abdomen close to your pelvis. It is not your stomach that is hurting. It is not anywhere near this region. What you are sensing is small bowel distension, that is, inflammation of the organ found in the umbilical and hypochondriac regions. Look at the location of the cecum and where the appendix should be located, in the right inguinal region. The appendix is 2 inches away from the right anterior superior iliac spine on a line from this point to the umbilicus. An inflamed appendix would present with pain at this point, although I should mention that pain from the appendix can present in a more complicated fashion, and this is due to referred pain, a concept we will discuss at a later lecture. The spleen projects to the surface on the ribs 9, 10, and 11, posterior to the posterior axillary plane. Imagine seeing a patient who is pale, complaining of pain in this region after a rupture gain. You have to assume an injury to the spleen. The patient is suffering massive internal bleeding unless proven otherwise. This is a life or death event for the patient. Moving to the pancreas lies in the transpyloric plane, deep to the stomach. Oftentimes, because of the concept of referred pain, pain from the pancreas will initially present in the back. However, in a gunshot to the belly, they can and will often be fatal because of injuries to the pancreas that project at this plane. Given these few examples of surface projections of the abdominal viscera, I've tried to impress upon you that even though the subdivisions of the abdomen into 9 regions is not generally done in everyday practice, nevertheless, doing so allows the localization of pain and tenderness, scars, lumps, and other items of interest, narrowing in on which organs and tissues may be involved. The need to know anatomy is simply not just for surgeons. It is a foundation for whatever system you plan to specialize in your future career. Knowing the surface projections of abdominal viscera, for example, allows you to perform a physical exam on your patient and potentially save their life by coming up with a correct diagnosis. This now concludes this brief introduction to the abdominal cavity.